rain and everything. All right, I will start the introduction. Good morning and happy National Doctors Day. I am Mark Biscone. I'm Executive Director of Operations for the ACHE Southeast Texas chapter. I would like to welcome you all this morning to a timely special topic presentation regarding optimization of COVID vaccinations. I will be the moderator for this seminar, so please send me your questions for the speaker via the chat function. We will address many of these during the end of the presentation and perhaps several during the presentation. We would like to thank our chapter sponsors for their support of this webinar and other educational events. Our charter members, Texas Children's Hospital, Houston Methodist, CHI St. Luke's Health, Memorial Hermann Health System, MD Anderson Cancer Center, and HCA Houston Healthcare. Our Diamond Plus sponsors, Medistar and the Intercontinental Houston Medical Center. Our platinum partners, Perlmeyer, Page, J. Tyler, Harris Health, University of Houston Clear Lake Center for Executive Education, Kindred Healthcare, EEPB, and our newest sponsor, Luminaire, as well as Texas A&M University, Brazosport College, Candeo Partners, and the UT School of Public Health. Please note we have several exciting events of interest, all of which you can register for at ache-setc.org. We will have our second quarter breakfast and panel on emergency management on Thursday, May 6th, with a preceding networking session. We will hold a networking event, Coffee with the Chief, featuring Noel Cardenas on Thursday, April 15th, an internships panel on Friday, April 16th, and an opportunity to volunteer at the Houston Food Bank on Saturday, April 17th. We will also hold a speed networking event entitled Power of Networks featuring Mike McBride on Tuesday, April 27th. So don't delay and register today. I would now like to hand this over to Beth Deladera to introduce Luminaire and today's speaker.
Hey, good morning. I am Beth Deladera. It shows up as Elizabeth, but that means I'm in trouble. I'm part of the team at Luminaire, and I am not talking about myself at all. I'm going to go straight into Dr. Sarma Bellamari, who is our speaker for the day and will wake us all up, I'm quite sure. So Dr. Bellamari is the MD and co-founder of Luminaire. Oh, I can't even speak this morning. That's the name of my company. Luminaire. He's a board certified internal medicine physician who served on process improvement across the city. He's involved in health informatics and patient safety committees. And he was named a lead hospitalist at Baylor College of Medicine Catholic Health Initiatives on the SEPSIS committee. He has also been the SEPSIS champion for HCA Houston, and he served as the medical director of Kindred Hospitals, which is a Fortune 500 company within the city of Houston. He's an active member of the Texas Medical Center SEPSIS Collaborative. He's worked with hospitalists taking care of transplant patients across the board, with LVADs while he was at CHI St. Luke's, and as an attending physician at Baylor College of Medicine prior to transitioning to HCA. He's been a guest speaker for the FBI's Biotech Security Summit. He has been a keynote speaker for Stanford University's Hack from Home Healthcare Innovation Hackathon 2020. He was appointed an advisor to TMC Innovation Center, which is a partner with the U.S. Department of Health and Human Services. He is driven to bring innovation to hospitals in order to decrease unnecessary suffering of patients. And his work with Luminaire was awarded Most Promising Web and IT Company in the U.S. by the Rice Alliance for Web and IT, and is part of the Texas Medical Center's Innovation Institute. And he is a fabulous person to work for. And so let me introduce you to Dr. Sarma Bellamari.
Thanks, Beth. Fabulous person to work with, hopefully. And I also like to say at the end of those introductions, all of that and $1, buy me a cup of coffee. So I'm really excited to be here. I see a lot of familiar names here. Before I share my screen and do death by PowerPoint, I just wanted to kind of share my story and how we got here. And so, like Beth said, I'm a recovering physician. I'm still, have a Texas license. I did mostly hospitalist medicine downtown in the med center here. 80% of my patients were, heart, lung, liver transplant listed or were on the VAD list. And I ended up on the hospital sepsis committee because my, patients kept getting sepsis, and I wanted to figure out, what can we do differently about 10 years ago. And the reason why doctor in a software company is, while I was on this process improvement committee, I helped write some of the rules that go into the medical record systems alerting system, the pop-up that goes off all the time that the nurses hate. Well, I was a part of that in the early days. I didn't obviously tell the nurses that I had anything to do with it, because I'm Facebook friends with a lot of nurses and I need those likes. So I just, kind of helped spoil the system. And then I started looking for better software to purchase. So about 8 years ago, I started looking on, to recommend to the hospital, we should go buy this software. And, it needed to be cloud-based, it needed to be, HIPAA compliant, it needed to do all of the, real-time metrics that we needed for sepsis reporting, to fix the billing and coding issues, to fix the clinical documentation, all of the stuff that your sepsis committee suffers with. And I didn't find any software. People were going, what do you mean cloud-based? This is healthcare. There's no such thing as cloud for healthcare. People will never have their health record on the cloud. And while I'm looking for this, my friend's daughter ends up in my ICU, and she was listed for 2 organ transplant, lung and liver. While she's waiting, she develops pneumonia, ends up on a ventilator, and then goes into septic shock on hospital day 3. And, I had recused myself from care. My friend was texting me. So, 4 in the morning, I get in my car, drive in. I get off the elevator and they call code blue. And I see that my friend is standing outside the ICU and he's crying. And so I go into the room, my intern and resident are doing chest compressions on his daughter. And, they get tired. I start doing chest compressions. And, 45 minutes later, I'm telling my friend that his daughter died from septic shock. And, looking in the computer, it was obvious to me that everyone did their jobs, like the doctors and the nurses. They all go to work and they, do their best. No one goes to work and says, today I'm going to miss critical data. And I realized that we could have done better if we just had better software, if we had better analytic systems, if life were different. And so I responded to that. I came home. It was the worst day of my life. It still that qualifies as the worst day of my life at work. And I came home, and like any normal, insane person, what I decided to do was mortgage the house and start a software company to build better predictive analytics, while cloud for healthcare was yet to exist. So that's the background of the company. We're, I think, in year 7 now, and I'll tell you a little bit about what we've been up to. Really appreciate Mark and the ACHE team having me speak here. I know I'm supposed to call it AIC, but I won't. And I told you the story, and the mission ultimately is decreasing mortality and unnecessary suffering. Our core values are integrity, safety, and compassion. And there's a lot of smart people who work in the company. We didn't get here just with me. My co-founder is Marcus. He lives in Houston. He's the CTO of the company. But everyone knows about sepsis, and this talk is not about sepsis, but I'm just pictorially telling you how we got here. These numbers are grossly underestimated, by the way. It's more than 270,000 people a year in the US who die of sepsis. Mortality is around 50%. People will tell you it's less, but if you actually go horizontally in time, follow people forward and see what happens, there's definitely a 50% mortality for sepsis that's not been intervened quickly. There's all kinds of nuances to it. And here's how I think about sepsis today. And it's based on the genome and the phenome, like the person's genetic makeup and how that's expressed, the medical record system you use, the type of infection the person has, environment, comorbidities. Geographic location in a hospital actually plays a huge difference in a patient's septic outcome. And Unfortunately, sometimes provider opinions play a big part in sepsis outcomes. The reason I bring this up, we'll come back to this slide in a second, but it's just there's a lot of factors that go into figuring out what to do about sepsis. And when COVID hit, we were in a presentation with the Center for Disease Control. So the CDC was using our software as an example of how to intervene on sepsis at HIMSS, which is the National, Informatics Conference. And we were in a partnership with the CDC, Cerner, and Philips, and we were talking about how to use software to improve workflow when COVID hit. And they looked at us and they said, hey, we've been on 10 conference calls that are basically talking about syndromic surveillance tools, like what you guys have done, guys and gals have done for sepsis. And I use guys in a gender neutral term, by the way. And they said, you need to take what you got and modify it for COVID. And because there's a lot of overlap, there's, if you think about, in the early days, cast your mind back to March last year, ERs were panicking because you didn't want a patient to come in with symptomatic COVID. You needed to have a way to figure out before they hit the ER if they were high risk for COVID and how to test them. And there's only, back in March, there was only, I think 500 tests per day available for the entire Harris County, 5 million people. So Harris County launched our software within 10 days of the CDC telling us to build something. We built it and then deployed it to a population of about 5 million people if you live in Houston. And then that spread to all of Texas regions 5 and 6. So for a couple of months there, while we didn't have testing, our software was the tool being used by both the healthcare department and the physicians who were calling in saying, does my patient need to be tested? They were being directed to our software to determine COVID detection. Okay, so, people call it a symptom checker. We're the original symptom checker. Our patent goes back to 2014. Why? Well, we've been symptom checking for sepsis. Well, then we said, okay, if we're doing symptom checking, like, why can't we, integrate it to an Active Directory, get your employee data? Why can't we add device data to it, do some real-time alerting, and implement return to work tools? And so we did that. And that particular tool today is we call it QUICKSCREEN, is being used by about 300,000 people a day to determine if it's safe for them to go back to work or not. And one of the best stories I've heard coming out of that method to go back to work is there's a citrus growers association. So these guys grow orange and lemon and citrus fruit. And they used our tool for people who are migrant laborers who don't have access to smartphones. And they basically, some of these people only speak Swahili, some of them only, they don't speak English. And so we implemented syndromic surveillance in about 14 languages. And they just emailed us last week saying, we haven't had a single outbreak in our population of migrant laborers in the last year. And we've had 0 days downtime. And they basically said that compared to other people in their industry, they've had an 80% improvement in efficiency from decreased sick days. We've implemented the same thing at a large two USDA meat processing plants here. And again, I'm getting to the vaccination story. It's important to for me to communicate to you how we got here. We got to this place where we're giving out vaccines in a very designed and purpose-driven fashion. When we built this, we started thinking about the vaccine that's coming out 10 months from now. And we said, okay, keep that in mind. So we organically made the shift to testing. So people said, okay, you're doing symptom surveillance, and why can't we just order a test through your platform for COVID, PCR or what have you? So we said, okay, so we implemented a testing pathway. And we were one of the first drive-through testing platforms that were launched. And, thousands of people have gone through the system. So we got to fine-tune the workflow. And all of that is important for the next thing that you're going to see about the vaccination. So how does it work? Syndromic surveillance via web. Do you have symptoms? Okay, great. hit a scheduling calendar, show up for drive-through testing. The administrators have devices that you just scan a QR code. They take a swab from you in your car. Pretty familiar process to everyone at this point of time. And then, we have a lab interface and it pushes data back and sends off an alert. Okay, if a person's high risk, you just slap a FDA class 2 medical device patch on them, send them home, and the patch talks to their cell phone and you can watch their vital signs from home. So great, we've implemented drive-through testing. So I'm standing out there in the cold in South Texas, looking at this drive-through testing, and I'm going, what are you going to do about your vaccinations? And they're going, oh, we're going to have this clinic model. People are going to get appointments. They're going to come, they're going to park, and then they're going to, get their shot. And I said, that's the shortest pathway between us and failure, is continuing to do things that way. And I said, why can't people just pull up and get their shot in their car? I said, well, is it safe? I said, sure, it's safe. I said, well, how do we do that? We said, all right, hold my coffee. And what we did was, it's the same pathway. It's people show up, they get their shot. We do batch and lot tracking. We report electronically. And they said, great, so let's try it out on the flu shot. So we said, okay, wonderful. So we rolled out a prototype on the flu shot. This is last year when there's still no vaccine like EUA approved. Like we knew something was coming and we said, we need to get ready for when it's here. And so they used it on employees, about 100 people in a parking lot. They came in their cars and got their flu shots. And we said, oh, wow, look at that. This thing actually works. And remember this slide from the SEPSIS? There's a lot of things that affect vaccination. And your brain is looking at all of this and you're in the moment and you're stressed and you have people calling you saying, you need to set up a pop-up center tomorrow. We're getting 500 doses from this other partner organization. And you need to have all of your staff trained. You need to have all of the devices. You need to basically somehow create a pop-up location somewhere else. Or people say, okay, we need you to fill in the blanks, give shots on next weekend on a Saturday. Now you have staffing issues. We need to, and I'm kind of preaching to the choir here, so I don't want to create more. Sorry, all of you live on my monitor over here, so we'll look here for a second. My point of this is not to create more stress and anxiety and fear, but what you're facing is faced pretty universally across the country, if not globally right now. Here's the thing, when you're being attacked by this multivariate problem set, your hippocampus is basically going on vacation. You're so stressed that you're just like giving up. If you're able to take something like this and turn it into a linear process, you'll find that you can solve the problem. And again, all of you are experts in healthcare, and all I'm trying to do is give you the perspective from the other side. I don't like to call it the innovation side because you all innovate every single day to work with what you got in the hospital. So people who have your jobs are frequently innovators. So what we did was we said, okay, let's break up this multivariate problem set into a linear workflow. And we implemented this. And let me tell you a little bit about what happened. So I'm sitting there, I'm incognito. I go down to one of these mega vaccination centers, and which is launching on our platform. And I'm in like PPE, I have a mask, I have a hood. And basically I said, I'm going to be here, I'm going to give shots, just give vaccinations. I want to feel the pain the people on the ground are feeling to see what we can do to make it better. We opened the vaccination center and it was 3 lanes of drive-through. And we said, we'll do 500 shots. If we have to be here till midnight, we're going to do 500 doses today, right? We draw up 250, we figured good enough for 6 hours worth of vaccination, right? And I'm sitting there going, I think we've grossly underestimated throughput. I'm suspicious that like we'll do more. So they opened the vaccine center. In the first 15 minutes, we did 250 doses. After 15 minutes of the drive-through center, we're going, where's the vaccine? They're like, you're done, 250 done. And we said, okay, we had to shut the drive-through down because we hadn't drawn up enough shots. We drew up the next 250. We had only accommodated for 500. They were done in 2 hours. And the reason for the 2 hours was we needed to draw out vaccine. And then we said, okay, what if you go upwards of this? Does this work for 2 lanes? Yeah, it works for 2 lanes. Does it work for 3 lanes? Yeah, it works for 3 lanes. You know where it's at today is we have launched the FEMA Department of Defense Dallas County Mega Center in Fair Park in Dallas. We have an 18-lane drive-through that has, I think, about 3 cars per lane. That site used to do 1,800 doses an hour. Now it used to do 1,800 doses a day. Now does 1,800 doses an hour. They used to have 5-hour wait times. Now they wait 17 minutes. And we don't know what the upper limit of their capacity is because we've never had enough people in the line to test that capacity. And there have been several days when some of the team actually get sent home because you don't need as many people on site to give out 10,000 doses a day. And I'm not going to bore you with this, but I just kind of wanted to outline that there's basically a methodical formula that we worked with Toyota and FedEx that you can apply to vaccination drive-through centers. And we've had sites that have 2 people running a site. They have, from the administrating side, they have 1 security guard and then 2 people. And they used to do 200 doses a day, and they go to doing, 200 doses in 90 minutes. And then they go, this is great. And I keep, saying this, that our stated purpose for the administrative team is that you get to go home in the evenings and watch Netflix and not worry about the data, not worry about reporting, not worry about all these other things that software should pick up for you. Then comes the problem of like, oh, we have a bunch of people in our community that want and need the shot. How do we bring them back in? We have a bunch of people who got their first doses, need their second doses. What do we do with all of that? So basically, we implemented a CRM tool. So it's like a customer relationship management tool, except we call it patient relationship management, where you're able to track like no-shows. You're able to invite people by text message, by email. If they don't show up, you can see what they did. You can see, oh, they clicked on the link, they filled out the survey, they didn't make an appointment. Well, let's go catch all those people because they clearly, maybe the appointment times were bad. So let's go re-invite those people. Or they took an appointment and then no-showed. Well, let's go catch those people. Maybe they didn't come in for whatever reason. Maybe the line was, too big for them, which never happens on our site, by the way. I'm kidding. And there's different reasons why people don't show up. So I used to pick up the phone and just randomly call some people to be like, hey, why didn't you show up? And I would obviously not tell them who I was. I'd just say I'm calling on behalf of this health department. Can you? And I'd say, oh, my son couldn't get off work. It's too far for me. Not enough advance notice. So all of these people are what we call as qualified registrants, and they basically have shown us proof of life, and we need to recirculate these people to get them back in. And so where I'm thinking at right now with this kind of process is think about all your heart failure patients. Think about people who should be getting echoes every 6 months who are not. Think about all the stroke patients who should be coming in for follow-up in a month, 2 months who are not coming in. Think about fill in the blank medical condition where there is a prescribed routine follow-up that all these people are getting lost lost in the wild. I think this is what we should be doing to chase our patients down to get them in and actually get them the care they need, but that's a different conversation. So this is not true anymore. This slide, it's not 20, it's probably closer to 30 or 25, 27. So we've having an ongoing rollout. We've, I think I was trying to count yesterday, done over 400,000 doses in the last 40 days, 45 days, and growing. I know that we're in a couple of other states as of yesterday. We've had a few more states sign up, counties in different states. And so that brings us to this map. And this is, we took the zip codes from one of our sites and basically put it on a map to see, where do the people live at, where, who've come in on our platform to get vaccinations. And this is self-reported data, so we're not like being evil. Almost every state there, and this is just from one of our sites. We we are working on collating all our data to, kind of create the same map. And I thought that was pretty exciting that, you could see, spread of an idea just because it works. Again, to be very clear, like it takes a lot of work on site, and we're just providing the software, and we provide the training, and we provide kind of the know-how. Ultimately, it does come down to folks like the folks we have on our call to make this effective, but our jobs have been to make it painless. So I'm going to actually hand over to Beth before I come back to my case study. Beth.
Okay, so let me, couple things.
Oh, wait, I need to do an intro. I have to do an intro for you.
Oh, no.
So Beth said I should introduce her as a recovering nurse administrator, quality improvement person. There you go. And so that's her exact words.
Oh, okay. No, it's not. But couple things. So if I'm doing this, I got my first shot yesterday. Yay. It was very different because I'm used to being on the front lines. And so I should have had it like a long time ago, and I was very jealous. And now I'm in my upstairs in between my children's bedroom doing this. So that's one thing. And by the way, Sarma does call himself a recovering physician. I think I call myself a nurse following the road less traveled. I've been an ICU nurse, a flight nurse, an administrative fellow, a administrator in outside clinics and things like that, and even like ophthalmology clinics. And then I did inpatient management in ICUs. And then my latest was service line management in one of the hospitals here, in a handful of different service lines, including critical care and hospitalists, which is what Dr. Bellamiri did. So that's sort of my story. And the other flip is that it aligns very much with this organization. My kick into the administration side was being in the middle of a COVID situation and not being able to get what I needed from supply chain. And my patient was suffering, the family was suffering, and the staff was suffering. So if we are focused on decreasing suffering, this is right up our alley. So it worked very well. And I really apologize for the way I pronounced Luminaire this morning. In Italian, it's Luminare, and it's bringing light, which is what the whole company is about. So on that note, let's talk about.
You just accidentally stumbled upon the right presentation. So when people used to ask us, we should say, well, in Europe, it's Luminare.
Yeah, exactly.
In the US, it's Luminaire. So
yeah, there you go. So there's the whole, it's circled back. Sometimes things just, boom, bring light. So we have to have humor. So this slide is important. So a couple of weeks ago, we had the quarterly breakfast, and it was outstanding to me how many pain points came across. It just, as sitting in a service line office or any incident command, just listening to the team and how much angst they had around the the COVID vaccination, just the COVID situation. We got used to managing within COVID, right? But then there's this whole thing of, oh, but now you have to vaccinate the whole city of Houston, which everybody just went, how am I going to do that? So, so that was really, required us to have sort of a rapid response quote to bringing this group together again and pulling some stuff out for the group to focus on, as well as an opportunity to talk about this again. And so on this, it's the inconsistency of vaccine availability is disruptive. That was the #1 issue. Okay, so we cannot get vaccine. We got it, we can't get it. That's hard. That was the previous. However, the real issue that came across, especially from some of the CEOs, was, now, wait a minute, we can't get it. But then when we do get a batch of it, we don't know when it's coming. We don't know how much we're going to get. We don't know if it is coming at all. And so our resources, we have to stand up these resources, sit down the resources, pull the resources. And that inconsistency, just, you can't plan anything. And when you can't plan, you're inefficient, you cause costs to go up, and you have stress. So that's a huge issue with this. then the demand for service is being pulled in several different directions. I mean, just all over the place. Think about, yes, we had a crisis. We have a crisis of, we already had issues with access and support, right? The health system was already, if you think about it in a triangle, the health system's foundation was a little rocky to begin with. I mean, we didn't always have staff. We didn't always have, and our margins were tight, so we couldn't spend the way we wanted to increase, grow our organizations and feed the community, do what we needed to do. So we're already a little rocky. Then we had a crisis, pandemic. So all of our resources go to that. Healthcare is really good at recovering from a quick crisis, but long-term crisis is not there. I don't think it is, and especially one this long. So you've added another layer. You've added pandemic crisis. You've added long-term pandemic. So that's super crisis and chronic stress. Like the hippocampus can't handle that. Neither can healthcare. Then you need to do your electives because your bottom line is even dropping even more, and you can't take care of this. And so somehow you have to figure out how to bring your electives back in. That's another layer. And then your patients that haven't gotten care for, a year and a half are coming in and they're super sick. That's why stroke is so high and heart failure is so high and COPD is exacerbated. So you have all these issues. And then, let's set up a vaccination clinic. Yay, something that's another service. Let's do that. It's totally fantastic, right? So your boss says, hey, go set up a clinic and set it up that's totally inconsistent and do it with no money. That's fantastic. And then the third thing you add on there is resources are diminished. So first of all, the pandemic didn't just hit the healthcare, it hit everybody. So you don't get the stuff you need. And the PPE issue was problematic up front. And by the way, it's still a problem because we're using more of it and we still don't have enough of it. But the real hit has been on staff in all over in the hospital. I'm going to focus on nursing and physicians specifically because I think of it as, fortunately, I think about it in the frontline terms. So you have a nurse that's living already in a staffing crisis. Then, they're already used to worrying about staffing every single day. Then you stress them, then they get tired, then there are options for nurses outside of healthcare. And so they leave. And then there's turnover. And, to replace one nurse is $150,000. It's a year and a half of nursing. Then you have a nurse's salary. And then you have to add travelers. And then this cycle goes on and you've increased your costs, you've decreased your engagement, and it continues and continues. And you're pulling people away from the bedside. And then the last one is you have no standard system in place. We were supposed to get help from the state of Texas to organize this process. It didn't happen. And so everybody's doing things on a let's figure it out, which takes time and energy. So we can now flip to the next one, the next page. So how a vaccine management solution can address that. Basically, how do we do this? How do we take care of it? So it allows us basically to, and I'm going to read this, it gives your organization more flexibility. Like I said, we can't plan right now because of the inconsistency, but having something in place, having a process that's clear, that everyone agrees on, it increases your ability to breathe and just take the next steps. In this world of no planning, it allows you to plan and manage those waves. The next is, you're better managing all your patients. Again, it's the same concept. You're organized, you're able to focus on what the patient needs, and you can sort of assess what's our wait list, what's the volume that's going to come in. And these are just, the walk-in ones, because we have to look at how we're going to do this with inpatients. And not a lot of work has been done around that yet because there hasn't been vaccine capability yet. The electronic reporting, which none of us want to think about, but that's a huge piece of this. Everybody wants to talk about getting the shots in, but the back end of data management and being in compliance and making sure we're HIPAA compliant and of other parts of that, and getting the numbers and getting everything into MTrack, that piece, we need to decrease the variability. We need to take the paper out of people's hands and ease that process, because that uses a ton of resources up front in these vaccination sites. And the improvement of employee morale is just again, taking that stress off the shoulders of people. Let's let them breathe. Let's let them do the work they need to do. The decreased variability across processes and reduced risk, that's sort of a repetition of the first one. All of us who do quality improvement, which is every single person in healthcare, because every day you have to look at the quality and safety of what you're doing. You decrease that variability and you decrease risk, and therefore, you decrease errors and everybody's happy after that. And then overall, you're providing services to improve the community health. And that is the key to everything we do. You get one shot in an arm, you're decreasing the spread. And so basically, in the end, when you can focus on what you're doing, on your core project and what is important to you, you basically are able to, sort of recover from the past, work right now in daily operations, and potentially move towards the future. And so this is what we think a vaccine management process can do. It can pull out that new service line of vax management and organize it so that you don't have to do that. And now back to Sarma.
So let's give our guest speaker a hand. Thank you, Beth. And so this thing of it, this bullet point provides services to improve health of the community. So we implemented a community-based vaccination program for homebound seniors in partnership with Nueces County. And the governor went down there maybe a month ago, and he looked at the model, basically went, this is great. And now they're rolling that model out across the state of Texas in partnership with the National Guard to implement community-based vaccination drives. And you can only do it because you're streamlining and optimizing workflow. And love these before and after slide kind of things. I'm going to show you this and then talk about the three cases, and then I'm going to shut up because I'm very eager to actually listen to what you have to say and hear what's happening to the people who do the real work. Here's some metrics. So I told you about the 1,700 per day moving to 1,700 per hour, and plus people start getting sent home because they don't need to be there anymore with respect to the team and the staff. I told you about the decrease in vaccine wait time. All you gotta do is Google, our company and COVID vaccination, and you'll see these news reports of 5-hour wait times, and grandma, had to pull over on the side of the freeway to a porta potty because she's sitting there for 5 hours. And actually I was going to write a blog post saying, I will not allow your grandma to poop in the car. And I mean it, there was people who unfortunately were having accidents in their car, and I was sitting there and it made me really mad. And, on day zero, and we had all these porta potty vendors out there, shipping porta potties to the side of the freeway. And, 5 days later, all the porta potty vendors come back and take their porta potties and take them back to construction sites, because throughput is something we understand, and workflow efficiency is something we understand. So very excited that even that produces value, not having to sit in your car when you're 80 years old and wait for 5 hours.
Sarma, I know you're talking about that, but let me just add that I just had a discussion yesterday with a health system here in Houston that did not have a diaper issue, but spoke to elder folks sitting in line and waiting and then their sugar drops and they have to go into a tent. So this still is a problem.
Right. Yeah. And I kind of use the porta potty as just as a kind of, I don't want to hear about that, but hey, you know what? We're talking hundreds of people. When you have 5,000 people in a line and you're only giving shots to people who are 70 and above, yeah, that's a problem. And I know that this problem is going away because of availability, but this is, we still owe even our younger people the right to not sit in a car for 5 hours. And then the no-show rate. So because you're being big brother and you're actually tracking people coming in based on a system level, not just Elizabeth didn't come for her second shot or Sharma didn't come for his second shot. you're actually being able to look at, let's look at all of these people who got their first dose on March the 6th who need to come in for their second dose. Let's figure out how many of these people have actually responded to our invite, have clicked on the invite, have picked an appointment time. Let's figure out who didn't. Let's, create a second vaccine appointment for these people to come in with an alternative time, and funnel all these people to that, and quickly set up a vaccine center for these 200 people. And you're laughing at me saying no such thing as quickly set up a vaccine center for 200 people, right? Okay, that goes to my case study. So Methodist Hospital System in Dallas, I get a phone call from the county judge, the president of the Methodist Hospital System, the fire chief, the head of the volunteer team, a few other people, and they say, we have 500 doses that we need. It's like 3 p.m. We have 500 doses that, sorry, it wasn't 3. It was, they were going to launch at 3. It was like way early in the morning. And they're going, we have 500 doses that we want to give out. We need to create a pop-up location today and bring 500 people to the site. We said, no problem. And basically with minimal training, they just set up a pop-up location in their clinic. We recruited people from the community, funneled them through the hospital. They got their shots. Someone from the county health team just delivered, 30 iPads to them. And it took very little kind of web-based training, and boom, 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 pop-up clinic done, check, move on. Same thing happened with a hospice center where they wanted to use a hospice center for pop-up vaccination, do maybe 100 doses, 200 doses, 300 doses. And the system was good enough that they've actually made it a habit. So this hospice centers basically said, this is not really hard, and we're not really having to burn a bunch of resources to do this. We'd like to continue to do community-based vaccinations. So now on a weekly basis, I think 2 days a week, they're doing, they started with, I think, like 250 doses. Now they're doing they're like, yeah, we can do 1,000 shots, no problem. So there are 1,000 doses are going through a community-based hospice for vaccination in the community. And now we've kind of also started working with EMS providers where Acadian, for example, is one of our partners where you can use your EMS team to implement vaccine hubs on a small scale. With that, I know that this sounds very much like we've solved all the problems. We haven't solved all the problems. We've solved a particular problem, which is setting up a vaccination center, getting high throughput, funneling the right people through it, or getting people through it, getting them back for their second dose and reporting it up to the state. With that, I'm going to stop sharing my screen. That's my email address. Beth's email address is firstname.lastname@luminarmed.com. And love to go into questions and handing back to Mark.
Sure, I think we have quite a few questions or discussion points in our chat here. Okay, here's one. How did you train the workers in the 18-lane drive-through process? How long did it take to get them up to speed? And where do you find the workers for that process?
Great question. I see Patricia asked a question. So it took us 5 days to set up the 18-lane drive-through. And I'm saying, like, on day one, there was nothing. There was a flat concrete strip, and we were out there taking pictures. 5 days later, 18-lane drive-through. We did dry run on day 4. And then on day 3, we kind of started using like staff to check the model out for the site. We routinely now set up, 5 to 10 lanes within 3 days of launch. Where did we find the people? You'll be surprised. There was an army of volunteers. On day 0, it was basically people who we just put out a call for volunteers. We had a volunteer coordinator team, and people just came in. There was doctors, pharmacists who were giving the shot, and then there was people from the community. I mean, I was out there pretending to be a volunteer also to see what's going on, and a bunch of these people were just professionals. They were dentists, engineers, and they're just like, we just took a day off and came in to help do this. And that model's actually sustainable. We still have a very large volunteer army that helps. But now the Department of Defense and FEMA stepped in. And the funny thing is we launched the site, made it process efficient before FEMA showed up and said, we'll help you with that. And so that was wonderful. Yep.
Here's another question. How do you, or did you navigate this vaccine procurement inconsistency and temporary medical assistance staffing agencies where, how do you tap into the other resource pools here?
That's a big one.
Yeah, Bruce, good question. Okay, so a couple of things with vaccine procurement inconsistency. Like that's hopefully getting better. One of the things we've noticed is standardizing reporting to MTRAC. There's a lot of dirty data issues. So what do I mean by that? It means if you report the incorrect lot number, it does not get deducted from the vaccine they gave you. And so basically they think you got more shots than you actually have. MTRAC has other nuances, like they don't take special characters in the name. There's all kinds of data issues associated with vaccine procurement that we've been helping clean. We have no power over who gets how many doses or anything like that. So we can't actually help solve that problem. But what we can help and have helped solve is when you get a call saying you're going to get 5,000 doses tomorrow or 10,000 doses tomorrow or 1,000 doses tomorrow, that immediate feeling of panic that you get of like, oh no, I have 100 things to do, that goes away because you basically have a button that you press and a well-oiled machine rolls out. And, so we've helped communities, counties, healthcare organizations build that process where you press the button and you know exactly what you need based on the number of shots that are coming in to implement, and you know where the people are coming from ahead of time. You can see at 9 p.m., oh, I have 1,000 shots, only 700 people have signed up. Let me go get another 300. You can recruit. So, we basically take away that panic response of the, oh no. With respect to temporary medical assistance, we've seen nursing schools actually play a big part. We've had a lot of nursing students show up and they do this buddy system where a junior person hangs out with like a senior nursing student who hangs out with like the preceptor. And you'll be surprised at how quickly they get up to speed. And I've seen actually a mega vaccine center operate at 600-700 doses an hour that was completely staffed with just nursing students and volunteers. Staffing agency, yes. So there are, because of what we do, we've had a bunch of staffing agencies pop up and come to us and say, hey, look, we're available if you ever have a site that needs like what we call as the warm body presence. So there are companies out there that do staffing that we train on our platform and our method. And from my understanding, that is FEMA reimbursable if you're a county organization. I'm not so sure if you're a nonprofit healthcare organization, if that's FEMA reimbursable, but again, not my area of expertise.
So can I add a little bit to that? There's a couple things that I've seen when it comes to, and this is just coming from someone that's had to justify finances for so many years, right? In a or nonprofit or a not-for-profit organization, it's all about justification to your leadership to make sure that you're spending your ROI, right? So think about a basic thing like this, in that the process that's been developed, what it does is, what we used to find is you have this turnover at shifts, right? One of the things, every 4 hours, you're changing your shift, changing your shift, changing your shift, changing your shift, reteaching. And so that's a time thing, right? And it's a time thing and it's a use of people and all that. If you can take, like we said, if you take 1,700 shots and, scooch them into an hour, just imagine what you can do to your day. Your efficiency is raised, you decrease those breaks between people. And in general, you're using less people to do the same amount of work, and using less people, same amount of work. And yes, there is an expense to that, but every time you decrease someone, this is really long, big picture, but every time you decrease someone that has potential for illness, That's one less person in your ER. That's one less person in your ICU. So you're down, you saving 3,000, you're saving 15,000. I mean, it's a big savings in the end. So when you want to justify that to your leadership in terms of setting something up, you have to look in the long term and they have to listen. And yes, some of it is reimbursable, some of it is not. There are organizations that are hubs and not hubs. The hubs are having the really big issue with the volumes, and the non-hubs just don't want to be in the business because they don't have it. The other thing is the organization has developed a waitlist process. So that issue of wastage is something that, Sarma, you can talk to that, because we're working on ways to decrease that wastage.
Right. Yeah, thank you, Beth. So two things I totally agree with, like decreasing process times, right? So for example, the city of Pearland, they were going to do, I think, 2,000 doses a week, and they were planning to run their vaccine center 4 days a week, Monday through Thursday. They launched the system and they're doing 4,000 doses in 2 days. And so they have 2 extra days where everyone goes home and hopefully is watching Netflix. And when I went on site, most people who go outside, their initial reaction is, where's all the people? And like there's a panic almost. Like I was there for launch for one of these mega centers, and the fire chief shows up and says, did the system break? I was like, what are you talking about? He's like, where are the lights? Where's all the people? I was like, you're actually like 400 people ahead of schedule right now. So yeah, no lines. You need to bring more people in if you want a line. And so decreasing the sheer amount of busy work a person has to do will help you with not needing as many resources as you think you need. Yeah, I'm just looking at the other questions here. How does this relate to CDC's VSafe messaging post-vaccination? Great question. So it's almost like in parallel. The CDC's VSafe is meant to be this like one-size-fits-all, centralized repository, which is great, but it's also an information black hole for healthcare organizations. If you want to reach out to your team and understand, when I say your team, I mean the people that you've given vaccine to or the community you're responsible for, that's usually not been very helpful. So we actually, I wouldn't say it's parallel, I would say it's divergent. It's like the people that you gave shots to are your people, and their health is, our responsibility to some extent. And so we kind of keep them in our platform. And Beth was talking about the wait list. We have some wait lists that have about 500,000 people on them. And it's almost like a registry that people are consenting to be on. We bring them in, they get their shots. Who knows what happens in September? I want this vaccine. I want the pandemic to end, because then I can go back to my regular day job, which is, helping hospitals solve sepsis and stop sepsis deaths in hospitals. Yeah, so we think of our platform as a patient management tool that helps you manage, your population. So Dallas County, for example, I think there's about 1.2 million people on that list right now. And I think we've interacted with maybe 250,000 people to date with respect to the vaccination in a month.
So if you see a place on the news with really long wait times, or a vaccine site struggling, how do you get in touch with them to help spread the good word and say we have a solution for that?
It's a great question. We've approached the Tesla model, which is we don't actually do much outbound marketing. And Beth was showing her cell phone. So we've had situations in which people Google the company and text us saying how much. And we're going, who is this? We're city of so-and-so. How big are you? So it's well, it's this much. And then they go, send us a contract to this email. And this is not with the sales team, this is with the customer success team, because their numbers published. And we're going, how about a product demo? And they said, yeah, we went to one of your sites, saw it in action. We'll do the product demo when you train us for launch. And it's again, I'm the founder of the company, so obviously I'm like extremely happy with the product, and I think it's the best thing since sliced bread. But ultimately, and Beth will, attest to this, and Natalie, who is our marketing team. Natalie, say hi, wave.
She is the team.
She's the marketing team that is supporting, I don't know, the
Everything.
millions of inquiries that are coming. But yeah, we're trying to figure. We've just kind of broken into other states. I know that we signed a couple of deals in other states yesterday, so we're excited about that. Most of um, our work comes through word of mouth and referrals, people calling each other and saying, hey, I know you have this problem, you need to talk to these guys. And if you have any ideas on how we can change that and how we should create an outbound marketing thing where we can send you all emails at 7 a.m. every day, please let me know. Very anxious to implement that.
So one of the things, I think that we need to think about is that one thing I'm going to share with the group is that, I've always worked for very large academic centers, always. And this is the flexibility in this small organization and the level of energy and intensity is the kind of thing you always want to see in your workplaces, right? You want to see people engaged to make better outcomes. But the cool part is this adaptability, and our healthcare, we're I hate using the term Titanic. We're I don't know, we're pushing, I don't know, a boulder up a hill, which is, I can't remember the Greek mythology one, but it's the boulder goes up and comes back down and whatever. So you're pushing a boulder up a hill to make any change. What I've seen that's significant about what we can do and what other folks are doing out there is this is new territory to so many people, and the partnerships with innovative folks in healthcare and other industry. One thing to be very aware of in your healthcare environment during a crisis is other environments can help and adapt. And what we've been able to do is sort of flip what they're doing. I mean, I've been so impressed where you take SEPSIS and then you end up doing COVID, testing, all that stuff. So there's a willingness to change. There's a willingness to say, let's go and let's make this better. So one of the things that I would ask the group either during this point or at another point, if you could provide feedback, is what are the other pain points that you think could make this better? Or what other areas? I saw one comment about cancer registry, and there's stroke pieces. There's all kinds of ways to improve workflow, throughput, efficiency. And that's really the bottom line. And to get things done faster, to get the patients and the families and the community the care they need. It is truly population management. It is making sure that our communities are healthy so that we do not use limited resources. And our teams are a limited resource. We have less nurses going into healthcare. We just do. I mean, it's just there. And staying in healthcare. Physicians, primary care physicians, don't have enough of those. People go, we have there's IT needs, there's supply chain, there's front end, there's so many needs. If we can streamline just one process and make the community better, then our needs are less pulled. So I know that's kind of a big concept and a big picture, but this ability to improve the community's health is something that every single one of us would like to do. And I'd love to get more feedback on how you think that we could help you guys. And any kind of examples that you have to share, because we live by cases. Every single day we have new ideas and new cases and want to make those changes.
Yeah, so I put in the cancer screening because I worked on a project probably 8 years ago at the VA, and they had a DHR back then, that was fairly mature, but the only solution was to add another alert for a provider to then go chase down the patient. So it was not an optimal solution because they don't need another alert. They don't need another job. They don't need that. And we were finding these patients that, if they were high risk and were supposed to come in every 6 months for their esophageal, exam, they would fall off the radar for a while and come back a few years later and have full blown, cancer. So, we said, we need to fix this.
It's so funny, Mark, like the plan on that particular Barrett's esophagus problem is we have an EHR interface that reads notes. So it sucks the person's note out. It basically reads, it looks for the word Barrett's and then figures out that the person has Barrett's. It'll go look for the path and then it'll show that, oh, okay, this person has confirmed Barrett's. It'll look for the last EGD and then goes, okay, ding, ding, ding. And it basically creates a active list where the administrator just has to push a button, the EGD like administrators, and it sends out the email and text message saying, hey, it's like, been 3 months since you just EGD coming up, been 4 months, EGD coming up, 6 months, time to come in for your EGD. You don't come in for EGD. You start getting literature on Barrett's esophagus converting into esophageal cancer, and the mortality rate of esophageal cancer at 1 year survival is 0. And so, you bet, people are going to come in for their EGD. And it's not a scare tactic. It's like you really don't want that person to progress into esophageal cancer. And the same thing with heart failure is you're due, class 2 through 4, you're due for your next echo. You haven't come in for your echo in 6 months. Please come in. You haven't come in. Here's some literature on mortality on raising heart failure because you didn't come in for your echo, you're not taking your meds. So our entire purpose is you can use a simple tool to drive compliance. And that's all we're doing with vaccination is we're improving workflow and compliance, which is what sepsis is about, is how quickly can you catch sepsis? How quickly can you mobilize a team of 10 people in some situations? And can you get antibiotics to that person in 60 minutes and be compliant with all of the CMS metrics, right? Every day, and you have 400-600 patients a day, and any one of them could go into sepsis, right? So it's the same problem to me. I just have a hammer, so everything looks like a nail.
Well, you mentioned compliance and you mentioned medication. So is there an option? Is there a application for pharmacy and medication adherence?
Yeah, exactly. So there's all these smart pill boxes out there, right? Which like use Bluetooth and all kinds of other fancy things to figure out if you're taking your pills or not. But here's the problem. Like it just measures, it doesn't actually drive compliance. In order to drive compliance, you need that interface back up to a system that says, okay, you need to be doing this, this, and this. Not only am I going to tell you about it, I'm going to tell your son who's taking care of your medications, and I'm going to tell your doctor, and it's going to be with your consent. Like elder consent is super important. So when you come on board, you actually give consent saying like, yes, I will, sign up to work with my healthcare team. And so I promised my board that we won't like implement any new ideas till we have successfully kind of pushed this one over the finish line. But we basically have a platform that we've spent years building that is able to talk to a medical record system, is able to talk to a telecom system, is able to read the record. So you'll hear things from us coming out about stuff you can do for stroke and heart failure in the hospital, but not for this call.
Okay. How about at some of these vaccination sites, have you seen issues with cultural disparity, and how have you guys dealt with it with this application?
Yeah, a great question. So what we found is people can't sign up if they don't have a smartphone, right? And if you text them a link, and people can't sign up if they don't have an internet connection at home. And there are counties which do vaccination on first come first serve basis, and they've been at it for a while. First come first serve equals to rich people. So what we've done is basically implemented mobile device management. What does that mean? You can park the software on an iPad, lock it down, give it to a bunch of volunteers to go out into the community and implement a community-based onboarding for people who don't have smart devices at churches, at community centers, at gyms, at YMCAs, at schools. And so we have hundreds of people every day who are volunteers. Today, there'll be 100 people out there with iPads who are in underserved communities onboarding people. And then transport is an issue. A lot of people don't have the gas to sit in their car and drive 6 miles to a mega center. So then we've partnered with the public transport organization. So you have a center where you come to, the bus picks you up, it ships you over. And then, I don't know, Natalie, is that video on our website? Maybe it's not. Sorry, I didn't mean to put it in the spot. So basically, I took a video of this entire process and just for fun. And so all these people get off a bus and they have basically a special line that they go to at a mass vaccination center where they get their shots. They go sit down, they wait for their 15 minutes, they get something to eat and drink through the Salvation Army. They get back in their bus, get shipped back. And so it's kind of like a turnkey end-to-end service for these folks, where you don't need tech. Also, the homeless people, right? So Houston's Healthcare for the Homeless back in March last year called me saying like, hey, any ideas on how we can like track spread among homeless people? And so we said, sure. We gave them a platform that basically allows them to do syndromic surveillance on the street with volunteers, figuring out symptomatology, track symptoms, guide people to, shelters to have quarantine, track them after, without necessarily needing personal identifiable information for that person. They get a serial number and you don't need to know their name and date of birth and all that stuff. And they've been on our platform for over a year. And they've had, I don't know if for those in Houston, you haven't seen major news articles about, COVID outbreaks in the homeless, because we've implemented syndromic surveillance for them for the last year for homeless people. We have one of the largest homeless populations in Houston, and Houston does syndromic surveillance to them through Houston's Healthcare for the Homeless.
Wow. Other questions?
Are there statistics on how many homeless individuals have been vaccinated so far? Great question. I can find out. I haven't checked, but I do know that one of our partners is in that community, Houston's Healthcare for the Homeless. I can go check. I don't know off the top of my head. There's a lot of mental illness, as I'm sure you know, with our homeless clients. And trust is an issue, and signing up for a vaccine requires a lot of trust that you're not being conspired against, or that there's no nanobots in the vaccine itself. So that's been an issue.
So we're coming into the sixth quarter of 2020, right? We're talking a little bit about this, fourth surge that's starting in Michigan and the Northeast with the variants as we're, launching the vaccines. What about, is there going to be a scalability issue that's faced by a lot of partners in getting the vaccine out as we're dumping more and more vaccine into the system?
Yes. So very interesting question, Mark. So I've been pushing this button which says decentralized distribution. And what decentralized distribution is like it says, it's decentralized distribution. You don't bring people into this classic, I'm going to get in my car and go somewhere model needs to go away. And we need to switch it to where can we as healthcare organizations be in the community providing care at the point of care. And I'm pretty sure that they're going to say in September that you can co-administer the flu shot with the COVID shot, and there's going to be a booster, unfortunately. And so, the scaling issue only occurs because we have a model that used to work last year. And I highly recommend people read Jurassic Park, read the book, not, watch the movie too. It's a cool movie, but read the book. So Jurassic Park is a good study in chaos theory and in complex systems. And basically the saying that people in my company hear all the time is the dinosaurs didn't die out when the ice age hit. They died out when the ice age withdrew because they weren't able to, not calling anyone or their organization a dinosaur on this call, I'm just saying. The dinosaurs died out when the ice age withdrew because to them, it was just another big change. It wasn't return to normal. And semi-returning to normal for us is another big change. And we as organizations need to acknowledge that it is another big change. If we expect life to be the same like it was in 2019, it's not going to be. Your patients have gotten into the habit of talking to their doctor on Zoom. They're not going to get in their car and come in. And that's it. That's here to stay, right? Unfortunately or fortunately. But you know what? We can use that to our advantage. We can use that to improve efficiencies, improve quality of care, improve a bunch of things, right? Like what I'm more, again, that's a different 1 hour conversation we can have about what that future looks like. But yeah, Mark, like the scaling issues will be seen if we don't change how we are kind of approaching distribution.
I think it was 2009 when we worked with avian flu, or that variant that came through, that we started doing the mobile vaccination units for flu. Have you had conversations about that going into
Yes.
the community and
We have several mobile vaccinations right now in the community. Like, this is the thing that I was talking about, the governors rolling out across the state of Texas. Is we built something called as a Save Our Seniors program, where the fire department takes like 100 vaccines in a cooler, goes out to nursing homes, signs people up who are, kind of homebound or nursing homebound, and gives out the shots, documents it in the community, and then you're done. And so they've been going out in pairs, so to speak, to give out shots.
Interesting. I was thinking also of the model of it where you have like the food truck pulling up in a community and getting your community members vaccinated. So in underserved communities, for example, too.
Yep.
How do you work with EHRs? How does your system, since we do have so many people on disparate EHRs in the state of Texas, even in our region, we have, Meditech, we have Cerner, we have Epic, how does that interface? How's that done?
Great question. So I had a little bit earlier mentioned that our SEPSIS product was being showcased by the CDC in partnership with Cerner and Philips. And the reason they were showcasing our product was on interoperability, because we have the glue that binds disparate systems together. So we're able to take data from just different sources, normalize it, match it to people, and then use that to implement care. Thankfully, in the last 10 years, EHR systems are much easier to talk to. So we integrate with every flavor of EHR system that's out there. Usually the kind of stuff that we're talking about is very simple. It's not like your PACS integration that takes like 6 months, right? It's who's this person, where they're from, what do they need, medical record notes, labs, that kind of stuff is sort of level 1 integration, which most CIOs go, are you sure that's all you need? I go, yeah, we're sure. They say, don't come back to me in a month and say you need more. I'm like, no, don't come back. We know what we need. This is all we need. And they say, okay, well, we already have that stream. If they want it, we'll just turn the hose to you. And so
awesome.
CIOs like us.
Yeah. So I came into healthcare from science background, so maybe a little bit more like medical training, right? We want to do an experiment where we change one variable and keep all the conditions the same and use that to study a complex system. So when I got trained in Lean, I said, well, this makes sense to me, right? We're taking a really chaotic or multivariable system and trying to make a process to make it more understandable and to control the variables. So when you tackled sepsis, was that some training that you had, or was that sort of just the way that you think, or did you partner with a process improvement person?
Great question. So I was on the telemetry process improvement committee as a young hospitalist because we were overusing telemetry. People were on tele for all reasons. And James Hearn, who actually now works at Luminaire, was the head of the CHI Six Sigma process improvement committee for telemetry. So I used to wake up and be on this committee at 6:30 a.m. every day, or not every day, but we met once a week, I think, for like 4 months. And basically, I learned process improvement and Six Sigma from just showing up to these committee meetings. And
Excellent.
James now works at Luminaire, which is like really, really ironic, 5 years later. And when we were on the sepsis committee, I went, we need to Six Sigma this thing. And, I literally spent a year waking up at 4 in the morning and going and shadowing nursing assistants around in the hospital and documenting workflow. Before I started rounds, all I would be doing is writing down every single thing they did, and including like taking the piece of toilet paper from the thing, writing down the vitals on it, going to the next patient's room, writing down the vitals, which doesn't happen in any of your hospitals, but just some of the hospitals I've been to, they were doing that, and just mapping out the process and keep on asking nurses like, I spent another 3 months basically showing them an iPad saying, hey, can you like click on this and see how you feel? Or can you like click on this and how does this fit into your workflow? Like, why would you hate this? And so a lot of this has just been like all other doctors listening to what the nurses say and then kind of taking their feedback into it. But it's not any special knowledge or ability I have. I just
And
have
you
a
have,
low threshold for sounding stupid.
yeah, and on this call, I know that we have some process improvement specialists in healthcare, so I'm sure they'll appreciate that. Value stream mapping, we can.
Yeah, so I'm a big Edward Deming fan.
Mhm.
And the highlight of my career has actually been teaching the Toyota people process improvement. I wouldn't say teaching them, but helping them with drive-through process improvement at vaccination centers, where our mega center up in Dallas, Toyota and FedEx were involved in that, and so I got to share some of my thoughts or our thoughts with them, and they were well received. And so I was like, oh, look at us, how far we've come.
Awesome.
But we're just getting started, just to be like clear, like we're small company, I think we're like 30 something people. I was counting, we have people in 4 countries now, or 5 countries who work with us. And our stated mission is to prevent unnecessary suffering and death, and stopping infectious related deaths in hospitals, especially, or heart failure related deaths and stroke related death is kind of the thing that we really want to achieve in the next 5 years.
Yeah. I was scrolling back through the chat, and Sandy Murdoch had a great quote here. Why don't you start working with voting lines and streamlining that now that you're building these governmental connections?
I will stay as far away from that as possible.
Oh, come on.
Nobody. I'm sorry.
But
it's just yeah.
I took part in the drive-through voting at NRG, and actually it ran pretty well. Maybe I hit it on the right day. I didn't go early on in the process, so I think they worked out quite a few kinks, but it was pretty smooth and didn't take too long. But
well, no, we need it to not work. We need it to not work.
I know. I'm sure places it did not work, but
I'm okay not doing that.
Now that we're starting to test, vaccines in children, is there a plan to work with school systems and schools with your platform?
Yeah, great question, Mark. So our system is in about 400 schools for return to school syndromic surveillance. So Dallas County, Dallas ISD, Uplift, schools in San Antonio, just around the country, like some in Illinois, some in Ohio. So we are already in a lot of schools for return to school. And it's interesting, we get these reports that, hey, you prevented a super spreader site today because this person was deciding to come to school when they shouldn't have, and we cut them off at the door. So yeah, we're poised to do that. Like Children's Health in Dallas is one of our partners that uses our product for school return to school assessments. So as the vaccine comes out for kids, or even for other immunizations, we're having healthcare organizations say, can we use this for all the other shots that we need to give out to the kids or to the seniors? So we're having conversations around that right now.
How about an interface with the vaccine passport idea?
Great question. So it's almost like you've been like reading my text messages. There's a lot of problems around vaccine passports. It's basically a universal identifier per person. And there's lots of things that can go wrong with that. Also, the World Health Organization had problems in the early days with the yellow fever card. There's a yellow card that you get when you get your yellow fever shot.
I have one from travel.
Yeah, and so that is one of the world's most frequently forged documents.
Wow.
And so so when you talk about accessibility and you talk about underserved, there is an enormous divergence that takes place when you start doing digital passports. So there's authentication issues, right? And so we're working on that. We're trying to figure out, like, how do you push something to clear, for example, right? Like if you're getting on your plane and you have a data feed, because we have, like I said, I think about 500,000 shots given to date. And so there is a very large population whose health records we have stored in very many different buckets. That short answer is we don't know. I think a bunch of companies out there are pretending to know. but it's a problem that's been in the developing countries. I can say third world because I grew up there and still a third world citizen. So it's a lot of the developing country problems that we've seen before, that, you know, digitization is one answer. And again, anyone on this call who has ideas on what we should do to solve that problem, like all ears, like we're eagerly looking for the best way to fix that.
We have a question that popped in the chat from Sean Curry. And in terms of logistics and processes, would anything change with the booster shots?
Good question, Sean. So with respect, it depends on if you're on our platform or not. If you're on our platform, you press a button and you're done. And if you're not on our platform, you have to basically figure out when they got the shot, what shot they got, what happened to them after that, did they have allergic reactions, etc. There's a laundry list of things that you need to go through. But in order to administer, we think it'll be easier because these are people who've already been through the process twice. And so they should probably be more compliant, less questions, you know, more people who are signing up for a booster are more likely to show up than people who signed up for a first or second dose. We think it'll be easier. Yeah.
Yeah, I think it will also help if you're co-administering or giving the option to co-administer a flu vaccine, an annual flu vaccine with your booster.
Yeah, I'm really hoping that they will allow that. I suspect they will, but we'll see. You can write my prediction down and see what happens in 6 months.
Or if it is endemic, you know, if they're just gonna mix the two shots down the road.
Yeah, exactly. Yeah.
You have quadrivalent flu and trivalent COVID.
Yeah, I just, you know, I'd rather not have that world where we need to trivalent COVID ourselves every year, but
yeah,
we'll see where it goes.
Okay. Any last questions? We're coming to the end of the 90 minutes. Or
has it been 90 minutes?
Yeah,
time flies when you're having a good time.
Fast.
And everyone stayed awake. All the people whose cameras were on were like, that was wonderful.
Otherwise, I'll give it to you, Sarma, for last thoughts.
Yeah, I just thank you, Mark. I just want to thank everyone again for like hosting us. I was telling Mark that I'm signing up to be a member if you'll have me. I see a lot of familiar faces and people I worked with before and familiar names. So nice seeing you all again. And if we can help you solve problems, we'd love to. That's what we're here for. So
exactly.
Thank you.
Well, thank you so much. And we will.
Question. This is recorded.
Yes.
And so we'll be able to share this with this group, right?
Yes, we're gonna post it on the website with a link to our YouTube channel, and you can even link from Luminaire, or share the link.
Thank you.
Thank you.
Bye.
Thank you all.
Have a good day.